I would now invite Dr. Rajiv Kovil sir for the next session. We have another session now coming up in drug reviews and therapeutics. And we have a topic which is talked about a lot in recent times. Benefit delayed is benefit denied. Initiating a once weekly GLP-1 receptor agonist. Uh, uh, Sir has spoken in last 2 days also in the conference and is well-known speaker, experienced endocrinologist in India, more than 20 years of experience, very good clinician and
thank you
speaker.
so much, Anjali. It was wonderful. I thought I will get some tips, and you cut short the earlier discussion. And Dr. Sanjay Kalra's comment that people call you bhaiya to uncle is happening, and that becomes a huge problem sometimes. You are spaced out for 2 hours. But I believe the organizers of conferences of IDEC has put this anti-aging filter. Both Neeta and you look much younger for some reason. So let me go to my topic, or I'll just keep talking on all this.
So you can talk on this topic for a little while.
Now I'm trying to see where my slides are. The slides are there. The slides are visible. Are my slides visible, Anjali?
Yes, sir. Yes. Just a full screen mode.
Yeah. So benefit delayed is benefit denied, and I hope my slides are moving. I'm contracted by Eli Lilly for this wonderful talk, and thank you IDEC organizers for having me here. I'm going to speak about how we need to have a multifactorial approach towards diabetes management, and also how to prevent complications by a multifactorial approach, and how a once a week GLP-1 actually fits into that multifactorial approach. Now, if you have two sets of patients, one with an HbA1c of 9% in the initial 5 years and 10 years later tries to get into control. A second set of patient whose initial blood sugar is better and then gets poor over a period of time. We have enough evidence from the UKPDS, from the Verify, from the Qatar study, from the ADOPT to suggest that we would like to go and aggressively control patients very early on to make sure that we get emergent risk reduction, not only in cardiovascular, but also in multiple other comorbid conditions. And a lot of abnormalities in our patients with diabetes drives both microvascular and macrovascular complications globally. And today we know that high glucagon or paradoxical hyperglucagonemia is a huge pathophysiological defect in our patients with type 2 diabetes. Now, if you look at strategy trials like the UKPDS Advanced, Accord, and VADT, UKPDS left off where the started off where the UGDP left off. And it tried to answer a very simple question, that is there any therapy which is superior to another, and whether we could we could get patients under good control, and whether we could prevent the progression of micro and macrovascular complications. VADT, Advance, and Accord actually tried to go like cowboys and said that whether we can go lower than what the UKPDS did, and whether we can get them to almost euglycemia using drugs which could have interactions, using drugs which could cause an issue, and thus resulting in a kind of a negative trial altogether. Steno 2, we all know, they told us that multifactorial approach is the real way of treating a problem like type 2 diabetes, which requires a multifactorial approach. And we all know that today a lot of studies have focused on glucose. We were talking about vascular aging. We were talking about how it can trigger chronic kidney disease, hypertension, and so on. And so HbA1c and cardiovascular disease is one and the same, and we need to realize that how can we reduce cardiovascular disease in people with type 2 diabetes, because that continues to remain the biggest killer in patients with type 2 diabetes as such. So how have we evolved? Now, earlier we were 2 decades back, we were thinking about HbA1c lower the better, A decade back, we were saying that we should avoid hypoglycemia. Hypoglycemia became a devil, whether it's a risk factor or a risk marker, we still don't know, but it clearly identifies people who are at risk for adverse outcomes. And in the last 5 to 7 years, since the SGLT2 and the GLP-1 trials came in, we have realized that we need to have individualized targets. We need to apply or add medications based on comorbidity, and we may not be targeting just glucocentric approach, and probably that will help patients in the longer run. And that brought us to a lot of change in guidelines, a patient-centered approach to choice, to guide the choice of pharmacological agents, including the effect of cardiovascular, renal, hypoglycemia, weight, side effects, and patient preference. And that's how we have been progressing as such. Now, what are the pertinent questions we ask or we would like to ask a patient before making him join the GLP-1 bandwagon? Importantly, whether he has presence of comorbidities, weight control, glucose lowering effect, hypoglycemia, practical considerations for GLP1-RA device dosing, and patient factors. Now let's look at presence of comorbidity or cardiovascular or chronic kidney disease. It's only 1/3, or I would say 25% of the patients that we see in our OPD practice has established cardiovascular disease. 75% of our patients do not have established cardiovascular disease. So whenever we try to extrapolate a cardiovascular outcome in patients with established cardiovascular disease or a CVOT with established cardiovascular disease, we may not have the same kind of effect. That is why this particular study of GLP-1 dulaglutide REWIND has a lot of clinical significance, because it's something that you can take home to the clinic and actually practice. Because one, it had a fairly equal gender distribution. Two, the HbA1c was almost closer to goal. So it's not the glycemic control which would have any bearing on the eventual outcome. And three, most importantly, 30% of the patients were the only ones who had established cardiovascular disease. So majority of them were patients with risk factors for cardiovascular disease, which are what we need to do, a risk factor profiling in patients with type 2 diabetes. So we are able to introduce evidence-based medicines to prevent progression of cardiovascular and chronic kidney disease, which seems to be the top two killers in people with type 2 diabetes. And if you look at what dulaglutide with his REWIND study did, REWIND was purely a superiority study, and it was a very long study. So when the study is very long, you get a lot of insight about the molecule. 5.4 years is a very long study, and because it had a larger cohort of patients with primary prevention, there needs to be a longer time to get substantial benefit. But you got divergence of the Kaplan-Meier curve very early within the first year itself. And that is extremely significant. And also speaks a lot about the safety and the durability of this particular molecule and once a week injectable like dulaglutide. If you look at its benefit in subgroups, whether the patient had cardiovascular disease or no cardiovascular disease, it was almost the same. It was the same whether the patient had cardiovascular disease or no prior cardiovascular disease. Whether the patient's HbA1c was higher or lower, again, there was no difference. So this was the first study which actually established the fact that GLP-1-RA would have cardiovascular benefit in patients with established cardiovascular disease and in patients with multiple risk factors. Leader, as we know, had majority of patients with established cardiovascular disease, and in the group of primary prevention, it was not significant. Again, this prompted the ADA-ESD to suggest that to reduce the risk of major adverse cardiovascular events, GLP-1-RA can also be considered in patients with type 2 diabetes without established cardiovascular disease. And what are these patients who have multiple risk factors? These are patients 55 years or older with coronary, carotid, or lower extremity stenosis of more than 50%, LVH, which we commonly see in our patients with whether it's an echo or an ECG, and an EGFR of less than 60. If you put this into practice, you may have almost close to 60 to 70% of our patients fall into this group, where you may have a lower EGFR, you may have an LVH. Any patient on one or two antihypertensives would have an LVH. To date, the level of evidence to support the use of GLP-1-RA for primary prevention is actually the strongest for dulaglutide, but lacking for the other GLP-1-RA as such. If you look at kidney outcomes, the USCR significantly reduced with dulaglutide versus insulin glargine. This is the AWARD-2 study, and again in patients with macroalbuminuria. And we know that we don't need any dosage adjustments with dulaglutide up to an EGFR of 15. When we talk about anti-diabetic agents, glucose lowering effect has to be right up there with the avoidance of hypoglycemia and with reduction in weight gain. And this particular group of studies, the award, was actually designed in such a way that it can actually help practitioners devise a strategy. So first and foremost, a lot of people believe that probably DPP-4 are oral preparations of GLP-1, or GLP-1s are injectable preparations of DPP-4. Studies like AWARD-5, where you have head-on of a DPP-4 versus a GLP-1 like dulaglutide, and lira-DPP-4 also clearly suggests that GLP-1 has a good pharmacological effect beyond suppression of the alpha cells, and the HbA1c reduction, it was statistically superior to a DPP-4 like sitagliptin, which is the standard of care in both the dosage of 0.75 as well as 1.5 dulaglutide. When you take a head-on versus other GLP-1, if you look at the AWARD-1, that is dulaglutide versus exenatide, which is short release, again dulaglutide was statistically superior in terms of its HbA1c reduction at the end of 26 weeks. Liraglutide has been the standard of care in GLP-1 for the last 7 to 8 years. Two studies prior to this, which two non-inferiority studies with once a week GLP-1 like albiglutide and the extended release exenatide, could not reach non-inferiority versus liraglutide, which was the Harmony 6 and the Duration 7. AWARD-6 study, which was dulaglutide versus liraglutide, achieved its non-inferiority versus liraglutide, just thus establishing the first once-a-week GLP-1, establishing HbA1c equipoise with the standard of care in GLP-1, which is liraglutide. Again, when we use injectable insulin as the first line of injectable therapy in people with type 2 diabetes, AWARD has two wonderful studies. One is AWARD-2, which is what we do in clinical practice, that when the patient fails to SU plus metformin, you may like to add on basal insulin, and the standard of care in basal insulin is glargine. And here you have once a week dulaglutide versus insulin glargine, and you see that the HbA1c reduction is statistically superior to insulin glargine. A combination injectable therapy, which was tried in AWARD-9, where you have a titrated insulin glargine added to metformin versus dulaglutide and versus a dulaglutide placebo, shows that if you titrate insulin glargine on the background of metformin, you can get only 0.67 reduction in HbA1c from baseline. But if you add on a GLP-1 to titrated insulin glargine, you have 1.44% reduction, thus paving the way that probably combination of GLP-1 plus basal insulin, or probably GLP-1 to start off, should be the first injectable in people with type 2 diabetes when they fail. And again, if you look at multiple real world data, some of them coming from India, also you will see that there's a significant reduction in HbA1c up to 2.2. Again, if you look at direct comparison versus dulaglutide versus liraglutide in real world studies, this is taken from the data from Italy. It shows that majority of our patients with dulaglutide are reaching an HbA1c reduction better than liraglutide. And in the AWARD-6, majority of patients on liraglutide were using 1.8 milligram, while in real world, we know that almost 95% of our patients use 1.2 milligrams of liraglutide, and dulaglutide at 1.5 is fairly well tolerated. Again, if you look at this study from Italy, it clearly suggests that the HbA1c reduction of 1.5 dulaglutide versus 1.2 liraglutide is better as such. If you look at the sustainability of HbA1c reduction, again, when the trial is long, you get this kind of benefit, and 5.4 years, you see that the durability or the suppression of alpha cells and the paradoxical hyperglucagonemia, which was a pathophysiological defect, which we had completely forgotten in the chicken and egg story of insulin resistance and insulin secretion, seems to have a lot of bearing in the durability of control, and that's what this kind of a study actually establishes. Now, if you look at weight, again, GLP-1s, again in the Award 6 head-on study, there is a 700 milligram difference, but you have to realize it was liraglutide at 1.8 versus dulaglutide at 1.5. Whenever you compare a GLP-1 versus injectable insulins, it's obviously the GLP-1s will be superior. In real-world studies, we see a close to 6 to 7 kilogram difference, and I have a patient with this therapy for the last 7 to 8 years who has lost close to 30 kilos and is maintaining that weight without addition of any other OAD or injectable for the last 7 to 8 years. Again, if you look at the GLP-1 Rewind data, as I said, majority of patients were using 1.5 dulaglutide versus only 16.5% taking liraglutide at 1.8. If you look at hypoglycemia, we need to realize that there's very low incidence of hypoglycemia. All incretin-based therapies work through the cyclic AMP pathway, and there's a glucose competence concept where the GLP-1 or the incretin-based pathways work only in the presence of glucose, thus making it insulinotropic. Adverse event nausea continues to remain higher. Pancreatitis, you hardly saw anything with dulaglutide. There was no difference between pancreatic cancer and pancreatitis between the comparator and the active molecule as such. Again, if you look at device dosing and patient factors, which is very important, if you have a good particular product in a mediocre device, it doesn't sell. And here you can see that the device has been taken care of, and once weekly where you have 52 injections versus almost 350 injections, there's a lot of difference, and you'll see patients choosing once a week injection. If you look at the dulaglutide pen, it takes me back to the Hero Honda advertisement, which used to say 2 decades back, fill it, shut it, and forget it. This is very simple 3-step process: uncap, place and unlock, and press and hold. Once a week, ready to use pen, pre-attached, hidden small needle. No need to a dose titration to improve GI tolerability at initiation. Again, if you look at what is the right choice of patients, again, patients who are inadequately controlled on multiple OADs, struggling to get blood sugar under control over time, patients who we should do a dietary recall and realize that these patients have excessive appetite, where weight gain is a concern. Patients have multiple risk factors, which could be an EGFR less than 60, LVH on an ECG or echo, or probably risk factors for cardiovascular disease. Again, motivated to take ownership of long-term health. Again, we need to realize that we need to move beyond glucocentric approach and a multifactorial approach, and that's why I call a GLP-1 like dulaglutide as a polypill, because it's highly effective glucose lowering agent with no hypoglycemia, with impact on weight and an additional benefit and reduction of cardiovascular events, and also can be used in patients with type 2 diabetes with CKD up to an EGFR of 15 per ml per minute. Thank you all for a patient hearing. I'm open to any kind of questions that you need to ask. Thank you.
Yes, thank you very much, Rajiv, for that very nice talk.